Yes, thank you and welcome for joining us today on this conversation about the mental health crisis occurring in Northern Syria. Joining us today are Dr. Alghawi, she and Hunadah, Nour, and Dr. Diab. Dr. Diab will be serving as our moderator today, and she is the director of the Center for Migration Studies at the American Lebanese University, and she also is part of the Global Research Network and part of our think tank on war, conflict, and global migration. I am Anisa Abeytia. I am the think tank program coordinator for GRN. With that, I'll hand it over to Dr. Jasmin.
Thank you, Anisa, and thank you everyone for being here. Our discussion today will hopefully revolve around a very important topic and one that is under discussed. We will hopefully look into the mental health crisis in Northern Syria through experts from the field, experts on mental health, and practitioners as well. We framed this talk based on the Syrian experience across the last few years, particularly the Syrian conflict and its impact on the mental health of young people, as well as people of all ages. We will discuss in a bit why young people particularly will form a center of this conversation as well. As a little bit of a background note, prior to the war experienced in Syria, the country was generally economically stable, and the median income placed the population regionally within the middle class. The war in Syria brought multiple destabilizing factors, massive destruction, constant violence, and the emergence of ISIS and other terrorist organizations, as well as protracted violence and conflict as well. Foreign militaries being present on the Syrian territory, as well as kind of the international lens through which this conflict is viewed, had a very dire impact on the psychological state of Syrians. Additionally, of course, this destabilization of the economy created high rates of poverty, and with this came the disintegration and scattering of families, as well as their displacement. The high level of conflict and violence brought with it a high number of individuals that are now living with disabilities, individuals that now live with illnesses. And due to a lack of services that contribute to the provision of services that support mental health has overall been declining within the Syrian context and among Syrian people, whether inside or outside Syria. Corruption across Syria is, of course, widespread, and the wealth is concentrated in the hands of the leaders of militias and gangs and in the hands of the few. The state of extreme poverty in Syria, of course, has dire implications on the community's mental health as well. And all of these aforementioned factors have left many Syrians in a state of despair, a state of real detachment from reality, and has led many of them to attempt or commit suicide. This is, of course, a description of the situation provided by someone working for an international organization in northeastern Syria who wishes to remain anonymous. However, I think some of the numbers might actually assist in framing this a little bit more deeper as well. Almost 1 in 5 of recorded suicide attempts and deaths in northwest Syria are by children, and the overall number of suicides in the area has risen sharply over the past year, jumping by about 86% in the first 3 months of 2021 in comparison with 2020, according to Save the Children, an international organization that is heavily present in this region. At least 42 of all those who attempted suicide in northwestern Syria in the last 3 months of 2020 were aged 15 or younger, and 18% were adolescents between the ages of 16 and 20, according to Save the Children's report. Partners of Save the Children, as well as Save the Children, confirmed that a 14-year-old boy actually took his own life in a displacement camp in Hama, in one of the most recently recorded suicides by the community. If we're talking a little bit in the areas of numbers and statistics, There have been 246 suicide cases recorded in 2020 and 1,748 suicide attempts recorded in the same year. The highest percentage where suicide attempts are prevalent is the age range between 21 and 30. This stands at 42%. This is followed by the age range between 31 and 40 that stands at 25%. And as the situation in Syria becomes even more dire, we can, of course, anticipate an increase in suicide attempts into 2020 based on actors on the ground and their testimonies and international organizations, as well as mental health experts. We are gladly joined by all three of them today. If I can tell you a little bit more about our speakers. Dr. Hala Alghawi is joining us today. She leads Med Global's programs in Syria and is an expert on mental health inside Syria. We are also joined by Nour Kormosh, who is a humanitarian activist in Northwest Syria and has worked in the field for the last 5 years. His work involves psychological support for children and youth. Nour particularly became interested in mental health due to the dangerous effects of mental health on the lives of Syrians, particularly with the increased rates of suicide cases. We are also joined by Hunadah Al-Hariri, who is a Syrian feminist and human rights activist. For the past 9 years, she has worked on projects that focused on empowering civil society with a special focus on women and persons with disabilities in the Syrian context. She has worked with different international organizations in different capacities, the most prominent of which is the Institute for War and Peace Reporting, as well as the International Medical Corps. She was able to gain more of an in-depth and cross-sector experience on Syrian civil society through her work with these organizations, and also through her management of the Dubai branch of a small public relations company in the UAE. She currently holds a BA in English Literature from Damascus University and is completing an MA in Global Affairs. Thank you all for being here today, and thank you all for your time. We can, I think, move on to the first question. The first question for all three speakers will be, coming from different fields, each of you offers a unique perspective on the current mental health crisis in Northern Syria. In order to contextualize the different multiple factors and understand how they connect, I'd like to begin by asking each of you to provide perhaps a background on your field. And thank you once again, Nour, for the statistics you provided. We'll begin with you, perhaps further to elaborate on these statistics, and then we can move on to Dr. Alghawi and then Hunadah. Thank you so much.
Thank you so much, Jasmin. Thank you so much, everyone. And thank you so much for giving me the opportunity to talk in this important issue. Actually, I have worked with several NGOs in regard to the psychological support and mental health for children and youth. And the most important, and it's not only the most important, I think the main issue is the overall situation that is deteriorating for the past 10 years in Northern Syria. Actually, the first 4 years were not as bad as the following 8 years in Northern Syria, as the mental health situation is getting worse and worse. By 2019, it has started, and media has been focusing on the suicide attempts and suicide cases that has been striking the youth and the children. Actually, the overall situation is not very encouraging regarding mental health or other sectors due to the massive absence of any life strings that these youth or children to hold on to. I think in the last couple of months, we have seen several suicide cases, and the reasons are various, either economic situation, financial reasons, and even existential reasons and psychological reasons. For me, it's more as a connection between the financial situation and the overall situation in general. The youth have literally nowhere to go. The clinics of the mental health care or psychological support are almost absent in Northern Syria, and even if they are available, their participation is very shy, and they are not doing uh, as they supposed to do, actually. And I'm talking with experience with one of the mental health institutes, which provides psychological support and mental health counseling, and the results were not actually promising, and didn't actually came out as I expected. These youth and children need centers that are specialized in providing psychological support and mental health counseling, and even the availability of specialized therapists and psychiatrists for these children or youth or even adults in these dark times.
Thank you very much, Nour. Thank you very much for your valuable input. Dr. Alghawi, would you like to maybe follow up on what Nour was saying and add a little bit as well of a mental health perspective? Thank you.
Yeah. Thank you for this opportunity to join you in this very important meetings or webinar, if we can say that. Actually, as I didn't choose to get involved in humanitarian fields, I didn't choose to get that specifically in the mental health and psychosocial support. Every field or every program I start to work in, I found myself in facing a lot of loss for Syrian people, which has affected their psychological well-being too much. Since I started my work with the Syrian refugees in Jordan, in camps, later on, or in working with the violation against human rights for survival of torture, later on working with GBV cases and assessing their well-being, I found that this component of mental health are not neglected only, but even when we want to interfere, we don't do the best practice to help these people. So this is briefly, maybe we can talk more specifically in the challenges and the barriers and also the situation or very bad situation for mental health and psychosocial support in Syria. Actually, if I can also have 1 minute or 2 minutes to explain that the pyramids of needs of people, it's started from the basic needs to community and family, then later on to non-specialized focused psychosocial support, then the last one is specialized services. What we have actually only maybe the second level or third level psychosocial support, which is not targeting or we didn't practicing these in a good way, basically, or based on the needs of the people. So like an example, if we go to provide psychosocial support for people living in tents, we are missing the basic needs, which is affected the psychosocial well-being for the people. And at the other hand, sometimes the people, they have all their basic needs, they are good, but there is no mental health services or specialized mental health services, which is help them to overthrow or overcome their suffering. So this is in general. I will let maybe the table for my colleague Hunadah.
Thank you very much, Hala. Thank you. Hunadah, please, the floor is yours.
Thank you so much, Jasmin and Nour and Hala. To be honest, this topic is very sensitive because we all agree that it is important. But I totally agree with what both Nour and Hala were saying, particularly when it comes to how the service is actually offered or provided, and how it is not, when we're looking at it, we're not looking enough at the context. Today, so my background is working in program management in civil society for the past 9 years, and my work focused on working with civil society groups and with media and governance to a less extent. And I want to particularly focus on women activists and journalists, as well as persons with disability. The reason why I want to say this, because usually when we speak about mental health, we always use the broader description of it, which is usually male default based. It does not take in consideration intersectionality levels of women, and let alone disability or displacement or socioeconomic status. So I think should be focused on, when speaking about the mental health, not only what Hala and Nour were mentioning about the context and how the security situation and the economic situation is a priority, but also on how to break down what mental health is for these people. And these are issues that I don't feel that we stand out enough, because usually we speak about mental health, let's have a psychologist, let's have a, but what do people think about mental health? What is this mental health is actually sensitive to the context and the culture? Do people who are working it are supported technically enough? These are all questions, and I think in the following questions we're going to describe more and more what are the obstacles that are being faced. But I think we really need to break down all these concepts. And the reason why I want to focus on women activists and persons with disabilities is that this group are, again, because they are not in the default groups, they are being outcasted often from programs or from the design of programs. So these programs, while even at the current, there are at a lot of faults with their design, but one big issue or one big gap is that they do not address all the most vulnerable in the society. And I think we're gonna discuss these later more, so I'm gonna stop at this point.
Thank you so much, Hunadah, and thank you all for keeping within your speaking time. I think we raised very important points. Often enough in a humanitarian setting, there are so many intersectional challenges that we need to navigate through. Nour discussed not only the conflict sensitivities associated with mental health, but also the financial implications as well, and how these intersections not only impact one's mental health, but their psychosocial well-being to a large extent. Dr. Hala touched upon a very important component as well about kind of the good practices and the lessons learned and the access to these types of services. Often enough, being aware of the need for the services is not sufficient. It really, people have to have a place to go, and I think that was a very important point. Hunadah, I thank you as well for giving us a wrap up of this intersectional lens and how vulnerability also happens, across different levels and across different extents. And I think that particular groups within the larger community in Syria do have layered mental health implications beyond, absolutely looking at it from a community level. We're talking about gender minorities, we're talking about women from particularly vulnerable groups, individuals that live with disabilities, etc. Thank you so much. If I may move on to question 2 and hopefully build on all of your experiences. Now that we briefly outlined, the background and we set the tone for the issue at hand, perhaps we can focus on what challenges prevent the delivery of mental health services, as Dr. Alghawi just attested to in question 1, so that we can strategize during our last question and propose potentially possible solutions. Dr. Alghawi, would you like to pick up where you left off and please discuss services for us a little more? Thank you.
Yes. If I can start to talk about the number of doctors and number of professionals who are working in mental health in general in Syria. Actually, in 2016, the health cluster started the technical group for mental health and started to train general practitioners from Syrian doctors on MHGAP program, which is aimed to to make most of the doctors who are practice medicine inside Syria able to provide mental health services to 80% of the Syrian who have mental health disorder. But what we're facing there, that the number of doctors are not enough. These doctors are not working full-time for filling this gap. At the same time, we don't have psychotherapists. I need psychotherapists who are studying clinical psychology, not only having some training for 5 or 6 days of training on psychosocial support. We need some specialists who can do this intervention psychosocial sessions, maybe 20 times for maybe 1 year or more than. So we don't have this number of doctors who can fill the gap. Even the trained one, they couldn't making full-time work for the issue of mental health. What we are facing also, that the short time of projects, the current projects, it's not giving the opportunity to train well those professionals, which they need at least 2 years to 2 to 4 years of training to be able or to be qualified to deal with these cases. So I'm just kidding when I mentioned that there is sometimes training 5 days to deal with suicide cases. It's not acceptable. It's not giving the real impact. So the short term of projects, not unavailability of doctors and health professionals, and also not providing integrated and comprehensive services. All these challenges and barriers prevent the people in need, the people who have these mental health problems, the people who are facing a lot of challenges in their lives, even at homes or relational lives, or even who have, and the majority of Syrians are facing this economic and poverty at their communities. So all of these put us in like a situation we couldn't meet the real needs to provide high quality health services, mental health services, I mean, with follow-up. This is, I think, the main issue and the main challenges that we face inside Syria in providing high quality mental health services.
Thank you very much. That was very insightful, Dr. Alghawi. Thank you for framing that for us. Hunadah, would you like to perhaps follow up in particular on the groups that you work with and how these services impact them as well?
Yes, thank you, Jasmin. And again, thank you, Dr. Hala. Now, there is a lot of, if we're speaking about challenges, and if I'm going to think about it off from the top of my head, it would be, for example, I would just say the economic situation and the security situation have a great toll on the mental health. And this is by far, like, this is one of the biggest factors. Yet I contacted, I just wanted to freshen up and see what is the action. Now, if you ask a Syrian woman, a Syrian activist inside, what are the most, the biggest challenges for you, which I did. And I was a bit surprised because it did not occur to me what they were going to say. But some of them said that there are no true programs that are addressing mental health in their description, which is, to me, is quite interesting, because they didn't, I would have expected with my own prejudices that they would tell me what mental health, like, just please stop. But actually they did not. They still think it is important, but they are not satisfied with the services. Now, whatever I'm going to say next, I really need to highlight that I'm not attacking service providers, because I do believe they are not equipped enough. And when I say they're not, or not, they don't have enough resources, which is almost impossible in a context like Syria. The whole population is under stress of different types. In every area, every Syrian, whether inside Syria or outside, will have certain type of obstacles facing them on a personal level. So I want to say that when we're speaking about challenges of the application of mental health, we cannot look at mental health in separation of the security situation, economic situation, and social situation, etc. Now, as I mentioned, I want to focus on women. And for example, women face a different type of issues, particularly when women activists, which is that they are judged based on much higher standards than their fellow men. Women's characters are at stake often, particularly women activists, and they are often attacked. Now, Dr. Hala probably knows, Nour probably know, in recent months, in Jummah Friday prayers, like Jummah, I was like, this is Turkish, like in Friday prayers, there has been Friday speeches that are directed at women activists. And this has created so much pressure that this has become a cause of suicide for certain activists. And not only that, there are now pages and Telegram channels that are actually creating a lot of attacks directed towards these women. So this is kind of social and security situation that I want to talk about. I know I'm running out of time. Just want to mention another factor, which is women with disability. Now, if you're a woman with disability, forget about it, because mental health is not sensitive toward disability. Again, not fault of only mental health. This is across all sectors. Because they are minority, although very big minority, 1 in every 5 Syrians have one disability. This is also an underestimated number. Yet the services, they would tell you, we focus on the majority because addressing the minority is not possible under the current resources. So, as I mentioned, there are plenty of factors, but what matters is when we're speaking about mental health, is speak about the groups that are not as visible as the default ones.
Thank you very much. Thank you, Hunadah. Nour, would you like to come in and perhaps close this question for us a little bit? Thank you.
Yes, actually, Hala really brought an interesting point, and of course, Hunadah also. Hala talked about the lack of professionals in regard to providing psychological support session or even mental health session. But I have to disagree with the point that the NGOs didn't really work out in an efficient way, because the situation in Syria has been going on for around I think 12 years, 11 years, and the NGOs have entered Northern Syria with psychological support programs and mental health programs since 2014. And I've been working with one of the NGOs and in 2015. And I think the NGOs have and had enough time to prepare staffs in regard to psychological support. And of course, mention the point that has been risen that we need full-time doctors and therapists. And of course, we don't only need therapists, we need a psychiatrist and a psychologist. And I'm, as I previously said, I have had an experience. I'm sorry if I ran out of time, but this is really important. I really want to mention it, although it's kind of personal. But I've really had an experience with one of the centers that is with one of the NGOs that I prefer to keep unknown. The NGO is working only in psychological support, GBV, mental health, and mental health in general. And the services were really bad. I felt like I'm in the middle of an interrogation, actually, and I was talking to a specialized doctor. She was a female, so it didn't make a problem for me that I'm talking to a female or a male at that time. But I felt like I'm being interrogated, and there was this other this other woman who's taking what I'm saying and asking me questions, and the doctors asking me questions, and it was really messed up. So the thing that we need also in mental health situations is accountability and monitoring and evaluation these projects. I mean, most of the NGOs think that, not most, some of the NGOs really think that providing psychological support or mental health services are just playing with children or giving them toys and so ever. When I used to work in psychological support sessions, I used to make the children write. We had this chamber, we called it the Chamber of Confessions, and I had them to write their fears, what they want, and how would they want to be when they grow up, and what they and the answers were really, really frightening. And I'm not a specialized mental health service provider, but what would have happened if the doctor I went to, the therapist I went to, really dealt with these children? And the ironic thing that at the end of this session, she told me, "You're gonna kill yourself." And imagine how that felt, like you're really talking to someone, and you want help from him, and you are shocked when he is telling you directly, without any like, "I'm sorry, your situation is," no, "You're gonna kill yourself." That's it. So the problems we're suffering from, and the issues are not really being solved, and we're just repeating the same mistakes from 2014 till the time being, is not considering the mental health sector as essential as other projects. And Hunadah said that the people in Northern Syria specifically, or in general, I really didn't listen, don't really understand what mental health is, and they need to understand what mental health and how to take care of it and how to ask for help. But a lot of people do, and I mean, as I said at the beginning of mental health services, people really didn't think a lot about it, because the situation was not as severe as it is now. I mean, it was difficult, but now, in addition to the previous situation, also the financial and the economic and the security situation in general is deteriorating, and people, especially youth from 14 to 25, really have nowhere to go, and asking for help is not as easy as it sounds. So we really need to focus on how to deliver the aid and deliver the idea. And also, sorry, someone's raising their hand. Yeah, go on.
No, sorry, finish, Nour. I just wanted to comment after you're done.
Yeah, sorry. So what I wanted to say is that we don't only need to launch the project and we just, launched a mental health project. We need to consider mental health project as essential as financial project, as essential as the NFI and SNFL projects, and deal with it as a whole independent and important project with accountability measures and monitoring and evaluation and continuous project.
Thank you very much, Nour. Hunadah, would you like to add something before we move on? Thank you.
Yes. Sorry, but I actually, something really important. I have to mention it, because what Hala and Nour said was essential and brought to my mind one very big issue, which is related to harassment, sexual harassment, abuse that is being done by people in the mental health sector. The problem here is not that this problem exists. It will exist in everywhere. But the problem is that there is no accountability system. There is no third party kind of monitoring. What we see and we know, and I think me and Dr. Hala, because I know her on a personal level, we know of cases where doctors were abusive, but there is nowhere to complain. There is nowhere for the victims to take their rights. And like, you know for sure, and it's not one victim, it's like multiple victims that have been sexually harassed or even raped by actors within the mental health or psychosocial support, and they know that there is no justice. So there is this very justified break of trust between people who might be interested in the service or need the service and the system, that they know there is no accountability, which is again a problem across the spectrum everywhere in the civil society. But because this is a sector that is trying to address an essential problem, if you do not have this credibility, that's it, then don't do it, because you're now definitely doing harm. So I just really wanted to speak about accountability, and it's absent because it's essential for the success of the sector. That's it.
Sorry, I'm gonna have to comment on very quickly. I'm really sorry.
Please go ahead, please.
The rule of the 5 minutes. I think Hunadah is mentioning and talking about GBV services in general. Actually, GBV services, I'm talking in Northern Syria, of course, some NGOs are really doing a great job in exposing harassments and exposing quote unquote predators, actually, those who the people that Hunadah is referring to, and measures really were taking against these predators. But some NGOs are really dealing with GBV, gender-based violence, as just talk, like just sit and talk, and they really are not providing any solutions and any accountability measures. Like, if, for example, if I were a victim of harassment and a GBV worker came to me, she's just gonna take my info, she's just gonna take my my personal information, just register a form, and that's it. And they might say, we're gonna get back to you, we're gonna see what we can do. But as I previously said, mental health services and projects are not being dealt with as important as other sectors. For example, I'm working in FSL and NFI, and if we had, for example, problem in the distribution, things will go crazy. Like, we're gonna know where the mistake is, who didn't take the share, who took it, and until the problem is solved. But when it comes to psychological support field or mental health field, they're not dealing as important as other fields. Yeah, sorry.
Just to quick clarify, no, I wasn't speaking about GBV. I was speaking about workers in MHPS, PSS actually committing crimes, and these might not necessarily be tracked by GBV because people, workers in GBV, because people will already be too traumatized by civil society to go to another level. Sorry, Hala, you wanted to speak. Sorry, guys.
Thank you both really for your insights on this. I think we're actually touching upon question 3 as we move forward. So perhaps Dr. Hala, you'd like to jump in and explain a little more about the numerous barriers and the challenges. There seems to be a gap on both ends, whether it's the quality of the services, the access to them, and the knowledge about the services. This was my third question to the panel. So please, Dr. Hala, if you'd like to kick it off. Thank you so much.
Yes, thank you. I want to actually, before I continue the discussion about this point, I want to stress that actually mental health and psychosocial session is number one to find a space for malpractice and also harassment and abuse sometimes. And no one maybe can have an evidence. No one can make sure or control the quality of services. So this is very important what Nour said, that we have to, and now WHO are working on monitoring and evaluation for the MHBSS projects and activity. And this is actually very important. Again, also Hunadah mentioned that there is all the programs and all the training from level 2, 3 to the specialized level of mental health programs and activity are not have the enough adaptation for the culture and to the faith, even around the world all the time. I don't mean only Muslim countries and other religious in all the world, they are including faith in any approach for psychosocial interventions. So this is a very, very important issue that we have to take care. So after maybe 6 or 7 years of intervention in mental health and MHBSS, we found an increased number of cases of suicide and also if severe mental health disorder. So why? We have to ask the question. Even most of the organizations are working in mental health, but not in a good practice, not in controlling the assurance or the quality, assure the quality of the services provided to the beneficiary. So we have to ask why. Why after this time of expertise, if we can say that, why we don't reach our aim or our objective for this project. So another things we have to work on, building the capacity of the Syrian local experts inside Syria, so they can have the ability to adapt these programs, this global standard to be locally acceptable and can be applicable. So this is very important. Also, long-term projects supposed to be taken in our consideration and donor consideration, and we have to advocate for this because 6 months or even 1 year, it's not enough to see the lessons learned, to see the real impact of our project on the ground, so we can have this study or what we have achieved in our project. So this is very important, building the capacity and including the local expert in any adaptation trials or programs for to be consistent with the Syrian context and its complexity actually.
Thank you very much. Thank you very much for a tie-in into our third discussion. Hunadah, would you like to perhaps respond to Dr. Alghawi, and then Nour, you can follow with your comments. Thank you so much.
Yes, thank you. I love the point that Dr. Hala mentioned because about the cultural sensitivity. Now, again, and remember I asked my female friends inside Syria, and they said that literally in this description, they said there is ready frames that are being applied to us that do not fit our society. And this is, may I say it out loud, it's Western frames, Western understanding of mental health. And this is again, one problem that we face across sectors. Now, definitely, like the Western approach to MHPSS is not actually utilizing a very, very important factor, which is the spiritual aspect, the use of the Islamic culture. Islamic culture has within it a lot that actually addresses this, and utilizing this could be a great tool to the benefit of the people. And it is something that is already a common practice, which brings me to what I wanted to suggest as things to do to address this issue. For example, it's very, very essential to understand that the numbers that we're talking about, if you look at the Syria situation and you look at the economic disaster, that the number of people living under the poverty line is massive. The security situation, especially in Northwest Syria, if you look at it, there is the shelling, there is the de facto powers, there is a lot of things that make you wonder why, in a very, do not take it literally, it's like, why wouldn't everyone want to kill themselves? Because there are actually, if you look at the situation now, you should wonder, it's like, there is definitely coping mechanism that we're not looking at when it comes to mental health, particularly for women. Women are under so much pressure, like even not living inside Syria, Hala and I, being Syrian women, can tell you that there's just so much, there is so much expectations from a Syrian woman. If you're a mom, you have so much on your plate, because it's not only your problems, it's the whole family's problems that you have to take care of. If you're a woman with disability and have a family at this intersectionality and you're displaced, I don't even need to mention it. Yet, these are the most resilient groups that you look at. These are the most strong, and these are actually the ones who can come up to you and give you amazing solutions to this. So to say it in more clear terms, I think we should stop looking at mental health as a top-bottom approach. It needs to come from the bottom up. It needs to be sensitized to cultures, and culture and religion and intersection, and different factors that influence people's lives. But most importantly, if we look at it, it should take in consideration the agency. Even if a person have mental health issues, that does not mean we should deprive them from their agency. This approach really need to change, because it's not useful, and people are not comfortable to work with insensitive or something, or a kind of service that is not taking their urgency in consideration. This is generally it, but there is a lot of details into it. I will stop here to Nour.
Thank you. Thank you very much, Hunadah. Nour, would you like to wrap up our question for us? You're muted, Nour. I'm so sorry. I can't hear you.
He didn't hear
Yeah,
the last
sorry.
question because he lost connection.
Oh,
So
you lost connection. So
Yeah.
in our last question, we were actually discussing a follow-up to our first two discussions. We wanted to discuss a little more of the numerous barriers and challenges in delivering mental health services. Dr. Hala began, the tone for this in our first question. We've been developing it with Hunadah as well, as we progressed. So would you possibly want to give any recommendations along these lines and wrap up our talk for today?
Where to start? Okay, first of all, we need to really re-advertise mental health services for the people in Northern Syria, because they have really some misunderstandings to the importance of the mental health services. And of course, developing an accountability management and monitoring and evaluation for the NGOs who are directly working with psychological support or mental health services, and even the importance of preparing and delivering this aid to the communities that lack centers. Like, for example, in my area, there's only one psychological support. I'm not going to say psychological support. I'm going to a psychologist available in a geographical area of I think a 25 kilometers range for thousands of individuals. And I've went to the clinic, as I mentioned, and I couldn't find a secure place and a safe place to speak. And not everybody as lucky as I am, as other people. And as Hunadah said, the female part are suffering the most in regard to mental health, the lack of mental health services, the courage to speak out, the courage to go to the centers and ask for help, and that's not and it's not easier also for males, so it's a two-sided problem, and that's it.
Thank you, Nour. Thank you very much. I see both of your hands up. How exciting.
Yeah,
All right, let's
it's
start with Dr. Alghawi.
Yes, follow up what I said about my recommendation also to adapt a curriculum that consists with the Syrian culture and also traditional norms, positive traditional norms. I mean, we have to also support research to start thinking about the best way of intervention, and also to build this curriculum to be adapted to the Syrian context and culture. Also, I highly recommend to support consortium of organizations to work together, because it will be they will be able to provide comprehensive and complementary services to the people in need. So it encourages them to provide these services at the same time or together with the basic needs. Thank you.
Thank you very much. Thank you, Dr. Alghawi. Hunadah, would you like to add your comment now?
Yes, I want to say a couple of things. Now, I definitely think that sensitization of the culture of the provision and the learning what existing coping mechanisms are very important. But one thing that is really very essential that we need to look at, and I'm going to say it through a scene that I've seen, which Dr. Hala touched upon, which is integrated kind of mental health. So here's the scene that I've witnessed. Someone comes to in a civil society organization. I want a salary increase because I cannot afford heating in my house, and I need like medicine for my children, and I have 100 stuff mentioning the million issues, schooling for kids, etc. Right? So listing down all the economic and social and security issues there. No, yet the response from the boss, no, I'm not going to address that, but here is mental health consultancy. No, no, I'm so sorry. But if at the end of the day, I'm talking about mental health, and the person who's going to receive the service going to go back and freeze in a tent or somewhere else, this is not really a proper integration. Whoever's like the sector of MHPSS need to, as Dr. Hala mentioned, this coalition should not necessarily only be with sectors that are working in MHPSS, but it should have a kind of referring mechanism to other sectors that could actually look at the holistic health of the person or presence of the person. And I think otherwise it would be really hypocritical to say, here is 100 great experts on mental health. That's not on its own alone if we do not address the other issues that the person is facing. That's the note that I wanted to make.
Thank you very much. I think we can open the floor for questions at the moment. And until then, I saw that Nour, your hand was up. Perhaps you'd like to maybe add a comment while we wait for questions.
Yes, just 2 minutes. The point that Hunadah and Hala raised, really, in 2018, I think I was the head of the Child Protection Committee in Just Shore City, and actually we've applied the same idea that they were talking about. We've been the coordination link between the special cases like mental health, or even the families or individuals that need financial or material support, with the NGOs that are providing the help itself. So it was a mutual work between psychological support and mental health services, and also financial and material providing services. So yeah. And it was really, really promising, but several stuff happened and we were unable to proceed. But it was a great a method to work and to follow as a mental health service provider or psychological support provider.
Thank you very much. I think that's a valuable wrap up to our discussion. So if we are to maybe give a bit of an overview of our recommendations and our gaps, there is definitely a gap, as we see in the MENA region, and the lines of communication between individuals that need this support and the service providers and the experts, where they are available and when they are available. We also touched upon the importance of intersectional approaches to vulnerable groups, whether from gender minorities, from groups of individuals who live with disabilities as well. And Nour gave a very, of course, raw and honest testimony of his firsthand experience of how these services are not only provided to people, if we want to call them services, but also, the detrimental state that they're in and how much reform is necessary in those areas as well. Before we wrap up our event, we'd love to take a few questions if anyone has any. You can type your questions in the chat if you'd like. Perhaps Anisa, if you'd like to add anything on this before we wrap up as well. I'm going to keep the chat open just in case. Anisa, the floor is yours.
Thank you everyone so much for this really necessary conversation. And, I wanted to have this event because the need is so great, not just within Syria, but within the context of conflict across the globe. And not just within conflict, but also with internally displaced people and refugees. Mental health services really are not being provided. Dr. Alghawi discussed about, we need more research done. And I recall, because I worked in mental health services for many years, and I work with refugees in Europe primarily, and this idea of locally led solutions from a policy side. This is what I focus on. Many people are local experts, are the experts on their region, and this very top down approach doesn't work anywhere in the world. And when we do look at the coping mechanisms, these studies that were done in Lebanon during the various wars there, they were done with a group of women, and they found that these women, even though they were living in an active war zone, their mental health, their self-reported mental health, was much better than women living in the Western world. And it was a coping mechanism that they had developed themselves and it was very, very much rooted in their culture. And that was after the children and husbands went off to work, they gathered for coffee and talked. Now, women a lot of times require discussion and kind of blowing off steam. Even with culturally, this idea of blowing off steam can be very much part of something that's developed. It doesn't require a Western approach. It doesn't require funding. It just requires a space for women to come together and discuss as a majlis. And I did this in the UAE with many women, and we solved many problems that they identified themselves, and they relied on them and resources that we had. So I would just kind of like to hear your take on, how to develop, would something like this work? Would something like this work for men? I'm not sure. And then we'll go ahead and turn over to you. We do have 2 questions, which is wonderful.
Thank you very much, Anisa. So speakers, would you prefer that we take everyone's questions and you answer them all, in one kind of answer, each of you, or would you prefer that we take one question at a time?
Well, I think we can take a lump sum kind of.
We can take a lump sum of questions. Okay, great. Thank you.
Yeah.
We have a question from Salah ad-Din. Please, if you'd like to ask your question, the floor is yours.
Yes, hello everyone, this is Salah ad-Din. Actually, I was thinking to comment about this very important and valuable conversation. It's not actually like a question, it's comment about the situation in Northwest Syria and highlighting in 1 minute. During this time, 1 out of 3 acute psychiatric unit in Northwest Syria just running right now. Unfortunately, 2 out of 3 right now are not providing the MHPSS services. Here we are talking about the specialized MHPSS services. Unfortunately, this is because the lack of fund in Northwest Syria. Another things related to the specialized intervention in Northwest Syria in general. And here is the point. When we are talking about the MHPSS, the mental disorders, it's something not like when we are talking about the distress or stress. When we are talking about mental disorders, I think, I'm not sure who is specialized here, but I know you have an idea. When we are talking about mental disorders, severe mental disorders, things here is life-saving. Here we cannot talk about anything unless providing this patient, for example, psychosis, severe depression, OCD, etc., the psychodrugs. If we are talking about the non-specialized interventions, this is another things. That's the level who provided by the case managers, the facilitator, which is very important in our situation. But here we have 2 levels of interventions and 2 levels of, let's say, response. I'm talking about this because I'm a psychologist and I'm working in the field of MHPSS in Northwest Syria with 1 Syrian organization. And last month I was there. So unfortunately, the mental health is not very famous. There is no a lot of fun for MHPSS. We would like, you will find a lot of funds for other, let's say, field or interventions, but for the MHPSS is not. I don't know why. Maybe because it's specialized interventions, there's doctors, there is psychologists, which is we don't have a lot of those people in Northwest Syria. We have just, I think, 2 psychiatrists in Northwest Syria. The rest of those doctors are MHCAP doctors, which is not specialized, but thankfully they receive training and provide medication for 7 mental disorders under the MHCAP program funded by WHO. If we are talking about psychologists in Northwest Syria, maybe we have 20 for 4.5 million population in Northwest Syria. So here is the point. We need, of course, the advocacy. I think the very important, let's say, player here can advocate and support. The MHPSS is the health organization, but unfortunately, not all health organizations, and doctors know that, are not fan of MHPSS. I don't know why, again. So we are talking about life-saving interventions, and based on WHO statistic, in the country like Syria, Northwest Syria, about 4 and 5% of people need MHPSS specialized interventions. Here we're talking about severe depression, psychosis, etc. So those people, if they didn't receive the medication, we don't know what they will do. This is not related to the, for example, choiceable. We are talking about something self-living. They need this medication. Otherwise, we don't know what will happen. Like someone have, for example, heart attack, or someone had cancer, he need the medication. That is the specialized interventions. And of course, but put into consideration the things you are raising here, sensitive intervention, etc. So things in North Syria is very complicated. I think if we are talking about the aspect of well-being, the human rights, the basic needs for those people, that will solve a lot of problems, but also we need the specialized intervention for the 4 or 5% of people who need specialized intervention. Thanks for this initiative and this conversation.
Thank you very much, Salah. I caught as much of that as possible. I had to move rooms for my connection, but thank you so much. I see that Dr. Muhammad's hand is up. Perhaps you can intervene, Dr. Muhammad, and then our speakers can respond to all 3 of your comments and questions. Dr. Muhammad, the floor is yours.
Yes, hello, everybody. Thank you very much for this opportunity. Actually, I will not talk a lot. I'm also still a psychiatrist working in Northern Syria, and I have experience with all the history of the mental health and psychosocial support in the area. I want to say one thing only. The international community, donors, actually sometimes failed to solve a lot of Syrian problems. And this is because they don't give the opportunity for Syrian experts to apply their thinking and programs. And they always, intentionally or unintentionally, they try to impose their ideas or their programs. Although they claim that they want to empower society, but when they meet empowered human resources, they don't give them the opportunity actually to do that. So just one thing, that if they fail to solve the political problems and all other problems, just leave us to try our own solution. And I think we will be in better shape if we given this opportunity to do that. So this is one message only that I want to convey. And thank you very much for all your contributions and your speakers, and for Salah and for everybody. Thank you very much.
Thank you very much, Dr. Muhammad. I see that we have one more hand raised. If it's okay with our speakers, perhaps we'll take the last comment and then each of you will respond. Rabi Kharbout, if I'm pronouncing your name correctly, please, the floor is yours.
Yeah, thank you so much. Hello, everyone, and thank you for this webinar. Actually, I want to highlight one point based on my experience. So I work in several community-based program. It should be, as I understand, from my experience, to build, any program or any project based on the capacity of the community itself. So once we realize that the need that we can intervene, so we can prepare, our intervention plan. Right now, in Syria, especially in the Northwest Syria, I think we have lack of sources, as we can see here. The specialized for mental health is very, very rare, and at the same time, we don't have many sources to depend on. For that, we need to ask about the donors, what they are commit to provide. This is the first. Second, for me, for example, I spent since the 2006 until 2015 my work in the humanitarian field, I didn't find like even one opportunity to get like psychosocial support. So until I moved to Turkey, I find like, let's say, these services became like much available for me. So this kind of thing we need like to focus first to make this service available, and before that we need to prepare the infrastructure at first and the human resource for that. So we have like to work on that first, then we can like start to map these kind of services. Thank you.
Thank you very much, Ravi. So perhaps for our responses and our rebuttal, we can start with Dr. Hala.
Next, yes, actually, I agree with Salah and Dr. Muhammad said, but I want to say that you can find health organization or maybe health professionals, not psychiatrists, but they are very interested in psychological issues, psychological disorder. So this is, but I think that the absence of quality assurance, the enough training, the short-term projects, and not and just making the psychosocial support like a recreational activity only for and considering people they are living in stable circumstances, not dealing with them like they are in very bad circumstances and they need the all basic needs to ensure their psychological well-being. It will be more effective, more efficient to meet the needs for all the people, including the most vulnerable one, elderly and people with disability and women who are living at tents and is very poor lives nowadays in Syria and even in the countries of surrounding Syria like Turkey, Lebanon, Jordan. So also we have to pay attention for those vulnerable and to try to design programs that can be adapted with the sensitivity of the communities and also to their culture and to be acceptable by them, not facing resistance. And I know a lot of people who are just visiting these centers inside Syria, like kind of recreational, but not for specialized services. And they seek for these services, it's not available, unfortunately. So thank you very much.
Thank you, Dr. Hala. Thank you very much. Hunadah, would you like to add anything before we wrap up? Probably in response to everyone's comments.
Yes, I would like to comment on what Anisa was saying about the coping mechanism that women have, and I have to 100% agree. In a group call that was with Syrian activists, women activists inside Syria, they were speaking, describing the situation that they're living in. And here's the thing: they are like speaking about a female worker. I don't want to name the profession because in public service. But so she was. They were telling the story. So this woman was being mentioned in groups and being accused of adultery. Mind you, she lives inside Syria. And this is like a killing kind of like, this is a big deal. So they were speaking how they contacted her and reassured her that she's not alone, and that whatever she's thinking, that like this can be getting over. So this kind of this woman was considering also killing herself, but this solidarity from other female colleagues, other female friends, made her more reassured. And it sometimes it's simpler than this, because it's almost impossible to be able to provide enough MHPSS services to the whole of North. So really, you need to utilize existing mechanism. As we mentioned before, like Anisa mentioned about the coping, about using the Islamic culture, but that's one thing. Now, another example that I want to mention as something else to be done, which is representation. Working with the groups with persons with disability, and they were speaking about how in Syria there's a lot of disability that came because of the war as an injury. So usually, so you can distinguish when it comes to the topic of disability, that disability you were born with. So that gives you kind of long-term coping that you have time to build on. And there's the I don't know what it's called, but this the disability that comes later in life. And to cope with this, even mental health experts would not be as sensitive as it could be unless they have received that specific technical support. So what that person said is that they have hired team members who do like social working tasks to go to the persons with new injury and talk them through it. But the person who goes there is a person with disability. So what I want to say is that representation in that topic is really important. But also our default is ableist. So most of us are acting from an ableist background because that's the only thing we know. So having representation, whether in terms of disability or in terms of gender or even displacement, could make the service even better. And I want to say thank you to everybody who asked a question and to my friends' contribution here, and for the organizers, obviously.
Thank you so much, Hunadah. Honestly, this was Anisa's orchestration, and rightfully so. Thank you so much. Nour, would you like to give a remark before we wrap up?
Actually, Hala and Hunadah and Anisa covered all the points, and yeah, thank you so much.